All right, so it is the April Power Lunch, and I thought it would be great to kind of wrap up the um, summaries of all the surveys. So we're going to go through today kind of the planning stages to kind of use some of this information in your planning because we're right at the beginning of the year. For most plans that renew in January, this is the time where people spend time and resources trying to figure out, what are the key drivers of our utilization and really what are the new strategies that we should be considering. I'm going to touch just quickly on the marketplace shakeup because I think it's important to understand what's going on behind the scenes that'll affect us in the next couple of years, and just be cognizant of that when you're building your new strategies. Then, of course, we're going to go into the actual surveys. And the surveys that I'm going to show you today are a culmination of the Mercer survey, which is our sister company. They're part of Marsh, so we're owned by the same company. Mercer runs the longest running healthcare survey in the US. I've also incorporated information from Aon Hewitt, National Business Group on Health, Willis Towers Watson, and PwC. So you're going to see kind of an aggregate of all of those surveys in the different categories. I also want to take a moment, a couple of minutes actually, to kind of, again, run through with you the key strategies that the survey is showing what large employers are doing and how they're doing it. And then throughout this, I really want to touch on how important your carriers are because some of these options that we're going to be discussing today are only available through certain carriers. So if you have a smaller TPA, some of these options might not be available to you. So it's important to know what your carrier capabilities are. So we're going to jump right into it this morning. This is exciting stuff. Everybody that knows me knows I love and live for this. But we are going to kind of talk to you a little bit about how you build your strategy with these survey results. So, of course, the beginning of the year, at this point in the year in April, you should have already met with your carriers, your carrier partners, to discuss what's driving your trend. So if you're a January 1st renewal, you should have already met with your carriers to get the utilization information, right, on what drove your cost into what they saw in 2017. I can tell you, if you take nothing else away from this PowerPoint presentation or Power Lunch, the key cost drivers that everybody needs to be focused on this year are specialty drugs, high cost claimants, and chronic conditions. So those are absolutely the top three drivers in almost everybody's utilization. But to dig down into what specific drugs in the specialty category, high cost claimants, how many, what the diagnosis and prognosis is, and then of course your chronic conditions, digging into that to kind of build your renewal and go out to bid on what strategies you want to deploy. Of course, one of the things that is definitely, Kelly and I were talking about this before the power lunches, just the crazy marketplace disruption that we're seeing. So it does appear, if you look at all of these acquisitions or mergers, it does look like the insurance market is moving into the provider arena. So United Healthcare is the largest commercial carrier in the US, right? They just bought DaVita, which is a physician network. CVS Caremark just bought Aetna, which they're hopeful to use their in-store minute clinics as a provider source. Of course, Amazon has pushed its way into the health insurance marketplace with Berkshire Hathaway and JP Morgan for their employees. But it does look like last week, this was breaking news last week, and it was interesting because it was very quiet. They actually put out, they made another bold move into healthcare, and it went relatively unnoticed. But they have reached out to Medicare and Medicaid recipients to get them to participate in a membership for over-the-counter drugs at a discount. So I don't know I don't know what that means. Nobody really knows what that means other than they're making a move into healthcare, and that's they're gathering membership information. Walgreens and Express Scripts alliance, that was something that was new in February. Of course, Albertsons wants to compete, so they were looking at buying Rite Aid. And then Cigna, a couple of weeks ago, just recently announced that they would like to purchase Express Scripts. Express Scripts is the largest PBM in the country. So that kind of surprised me that Cigna was looking at buying Express Scripts. You know, last year, Anthem, the largest Blue Cross Blue Shield plan in the country, tried to buy Cigna, and Aetna tried to buy Humana, and both were stopped because it was deemed by the FTC that it was anti-competition. So most of these mergers and acquisitions still need to be approved. We'll wait and see how it pans out. My opinion on these acquisitions and mergers are it's definitely a shift in the marketplace, and we have to be watching this stuff from a macro perspective just to make sure that we understand, how it's going to impact us as employers and our cost. And I think one of the things that obviously concerns me is the PBMs are coupling back up with the medical carriers. And we've just done, 3 to 5 years of uncoupling them on our side, trying to go directly to the PBM for pharmacy benefits and medical carriers being separate from the pharmacy. So over 60% of employers right now carve out pharmacy and go direct. It's enabled us to get better pricing, 100% of our rebates, and more focused management. So the one thing that concerns me is obviously with them kind of coupling back up again, are we going to lose some of the pricing advantages and the significant focus that we have? Pharmacy is the number one concern with employers this year, and it's the number one driver of trend. So there are some benefits, not to be completely negative on the mergers and acquisitions. There are some benefits with coupling back up and having both the pharmacy and the medical run by the same entity, in that, the medical management or the disease management, just the overall medical management should improve if you have one person in charge of looking at the pharmacy and the medical. Although today we reintegrate the data within 24 hours. So the medical carriers should be able to see all of your pharmacy data in almost real time today. So kind of moving through, the state of the market piece and what's going on in the industry. Price is definitely driving trend. It's not utilization. This was big news last week, and I'm not sure why. It was top of the page on the Wall Street Journal, and the USA Today ran a story. And we've known this, so I'm not sure why it was such big news last week. We've known this for a while. And predominantly the cost is driven by 2% of your population on the specialty drugs. So if you look at this slide, and we will make all of these slides available to everybody after the power lunch. So if you want to look at these more carefully, I know I'm not going to read each piece of them, but out-of-pocket costs for employees are up, employer costs are up, and significant increase in the pharmacy piece. There are a lot of initiatives going on to control that. We're going to talk a little bit about those later, certainly in the PowerPoint. But if you look at all of the surveys, every survey estimates the cost or the trend for 2018 to 2019 a little bit differently. But after plan design changes, Mercer's at 4.3, Aon's at 4.5, National Business Group on Health is at 5% increase. Willis Towers Watson's at 5.5, and the survey from PwC is at 5.5. And that's after plan design changes. So I think in 2018 going into 2019, we're probably going to be looking at increases between 8 and 10%. And then after we do some plan design changes and cost mitigation, that's where they're thinking that will be. I think the biggest thing to point out there is from 2017 to 2018, that's a pretty big increase. So we were at 2.3 to 2.5 in 2017. And the key driver in that statistical increase is pharmacy. This is just a quick slide to talk a little bit about the average cost per employee. And I will point out, in looking at this slide, the key thing that we need to be cognizant of, I think, is that the excise tax, the Cadillac tax, whatever you want to call it, is still out there for 2022. So they didn't eliminate it, the CBO, and I think most of the folks that have looked at healthcare reform have recognized without that excise tax, they can't pay for healthcare reform, the money that they already spent. So they keep kicking the can down the street, right? It was 2018, then it was 2020, and now with the most recent change, it's 2022, but we're already over the excise tax limit. So anything you're over by, you will have to pay a 40% tax on. So something just to think about and be careful of. Biggest concerns, of course, I just wanted to put this slide in here because I think it's important that you know what to focus on when you're looking at your strategy right now. And it's certainly specialty pharmacy, high cost claimants, and disease management because we have so many chronic illnesses. Over 52% of the United States of America has, 52% of our population has a chronic illness or chronic disease that they're on a maintenance medication for. System waste, those of you who attended the San Francisco conference, 1/3 of total spend, over $1 trillion a year, is on unnecessary or inappropriate care. So that is something that we have to focus on as well. And a lot of the initiatives that we're going to talk about in the survey are geared towards the focus on those 3 top drivers of cost: specialty drugs, high cost claimants, and chronic disease and chronic illnesses. I love the slide because it's just such a mess. It just basically is our whirling dervish of healthcare. It's trying to figure out what is it that we should do this year. I think most employers, at least all of my clients, we want to be thoughtful about the strategy. We don't want to upset the employees. We offer benefits for a reason. We offer benefits to retain and attract good employees that run our businesses. So when we think about what changes we want to implement or institute, we want to be very thoughtful about what those changes are. So there's a lot of options today. There's, the value-based care initiatives, the pharmacy solution. Should you carve out? Should you leave it carved in? Empowering people with the consumer-directed health plans that are front and center now. And really looking at the holistic person in perspective of the benefits with retirement and healthcare. I think it's fabulous that the conference that we attend 4 times a year that Kelly and her team runs really kind of brings those two together, because I think more and more employers are coupling financial well-being with healthcare. Because there's a lot of statistical or empirical data that show that financial stress and financial unhealthiness impacts and flows over into the healthcare space and the benefit space. So we're going to jump right into our survey. Again, these are survey results that I've added and averaged all of the different surveys together. If you look on my website next week, I will have this all broken down. It was just too much to do in 20 minutes on a power lunch, but if you want more specific data based on your industry, I should be able to have that out on my webpage shortly, some information, more detailed information, so to speak. So plan and cost type differs by industry for sure. So, and I think this kind of a little bit, this data surprised me. So consumer-directed health plans are definitely the highest enrollment plan type for 2018. And, 2 or 3 years ago, they weren't. So that's a big shift. And I think I broke it out by industry because I think it surprised me a little bit. I would have thought retail would have been a lot higher than 53%. But if you look by industry, banking is at 60, technology is at 64. Healthcare still, they have very, very rich benefits, so that's still at 25. Manufacturing, 71, grocery and product industry is at 40. And of course, the insurance industry, lastly, is at 57. HSAs are the most predominant savings account that are coupled with consumer directed health plans today. And I gave you at the bottom the average employer contribution for employee. They're contributing $650, which again, I think it's more like $800 in 2018, but that's the average of the surveys. This isn't my opinion. But I see more, between 800 and 850 at this point. Family coverage, a little bit over 1,000. So in the past couple of years, the prevailing wisdom was the consumer directed health plans were going to help us control cost, right? So we wanted people to have skin in the game. And I think it was a very, very good strategy in helping employees become better consumers. So we want people going to the pharmacy and we want them to have money in their HSA that they have to spend out of pocket before they hit the total deductible, before the plan covers it. And having them walk in and say, is there a generic alternative to this $300 medication, is a good thing for all of us. But I think what we've seen in the last 24 months is that the significant difference or the significant change in what we're seeing is it's not the general trend that's being affected by 80 to 90% of the population utilizing our plans. It's really, the 5% that are spending 90% of our dollars. Even now, it's less than that. It's almost 2% of the population spending 90% of our dollars. And those are the people with the high cost claimants, right? Your large claimants and your people on specialty drugs. So I think the renewed focus is the consumer directed health plans have kind of done their job and kind of made everybody focus a little bit more on having skin in the game and becoming better consumers. But now employers are moving into 2018 and 2019 with some different goals and objectives on their agenda. So the survey says spousal surcharge are at 35%. This surprised me. Wage-based premiums at 34%, different cost share based on your wages. Mental health and behavioral benefits. This was interesting to me, so I included it. Manager training, employee training, and anti-stigma campaign. Those were pretty large movements within the large employers. Pharmacy carving out the PBMs through a coalition definitely was the largest. So employers are taking advantage of bulk purchasing or leveraged purchasing. So a pharmaceutical coalition is basically like the one that Tryon has, where we've gone to the PBMs and said we want preferential pricing, terms, and performance guarantees based on representing over 800 employers. So you get your own contract and your utilization isn't commingled, but we're basically pre-negotiating the deal on behalf of our clients, and then you still have a direct contract with the PBM. That's the part that's changing a little bit with the acquisitions of Cigna with ESI, CVS with Aetna. Optum is the third largest PBM, and they're owned by United Healthcare. So you can still go direct to those PBMs. But if you have one of the carriers that is coupled with the PBM, you'll be integrated. And of course, integrated is down to 22% with the medical carrier. And then going directly to a PBM without going through a coalition is at 18%. Prevailing pharmacy strategies, I'm going to expand upon this in my more detailed explanation of the surveys that I'm going to be putting on my webpage, but you can see the top strategies that I kind of picked out based on the statistics are a closed formulary. We've all recognized the compound medications have been a significant problem. I'm surprised the 78% isn't higher because most of my clients have eliminated them and only allow compound medications based on pre-certification. Drug tier different. I'm not a big fan of that, I have to say. 38% of employers have a different copay for specialty drugs. And dinging somebody for $300 instead of your regular name brand copay, it's not going to make a huge financial difference. And those are the sickest people in your population. Those are the people on a specialty drug with a rare or unusual illness. I just think there's better ways to manage it than having a specialty copay. If you do have a specialty copay, I'm hopeful that it's affordable, because one of the things with those specialty drugs is they're so expensive. You want to make sure people are taking them appropriately and not trying to stretch out their medication. So the adherence part is the part that concerns me with the specialty drug copay. We want to make it easier for people to take care of themselves and be adherent, not harder. And then the last bullet point is a big one. So 71% of employers have a specialty drug pharmacy PBM. And what that means is, like with Express Scripts, they have Accredo. It's a specialty drug arm of their PBM that they have groups of employees and pharmacists in each category of drug or illness. So with the MS medications, for example, there's a lot of new multiple sclerosis medications that have come out on the market that are specialty drugs. They require special handling, special temperature control, special delivery. They want somebody to reach out to the member prior to getting that drug to talk about the side effects that they're going to experience. A lot of companies are doing split first refills, or split first fills, meaning if it's a new specialty drug to a new member, they're giving them a 15-day supply instead of a 30-day supply in case there's side effects. The person is, if it's a $3,000 a month drug, it'd be better to lose $1,500 instead of the $3,000. And the employee gets a benefit, or the member gets a benefit, because they're only paying half a copay. So that's another big strategy. And then, of course, using the ACOs, the Accountable Care Organizations, that is really front and center this year, with the large employers looking at hospital systems that are giving preferential pricing. Again, your carrier partner has to participate in these ACOs or narrow networks, and that's something that you would want to talk to your carrier about. But this has come downstream significantly. So it used to be, the Fortune 50, the Fortune 100 companies used ACOs or narrow networks, and now that's come downstream because a lot of the carriers, including United Healthcare and Anthem, have special narrow network options, and Aetna, of high performing facilities or ACOs where they get special pricing. High performing networks is at 19%. Centers of excellence, I kind of broke this down because it differs. Transplants are huge. Cancer's increasing, I can tell you. It's at 30% for 2018. That's going to jump significantly because there's been a lot of development on centers of excellence with Sloan Kettering, MD Anderson, and some of the other cancer specialty places, where they're focused on certain types of cancers and treatments. The growth of telehealth, obviously, most companies have moved into trying to get people the availability, especially with two working people in a family, the availability a little bit easier. On-site health centers, that's at 55%, and those have come downstream a lot too. It used to be that you had to be over 1,500 or 2,000 employees in one location to offer one, and that's changed. The transparency tools are way up just due to the consumer-directed health plan push. And then the last one is a big one for me, the disease management and the coaching. So again, those high claimants and the people on specialty drugs fall into this bucket. You really need to focus on that, and value-based plan designs and folks rolling out value-based plan designs have really become forefront. And really just wanted to show you, when I talk about value-based plan designs, what am I talking about? It's incenting people to participate in coaching and disease management, or really looking at offering them free care without a deductible and coinsurance if they go to a center of excellence. It's looking at condition management, where you're saying to your diabetics, if you participate in our diabetic wellness program, we're going to waive the cost of your diabetic medication, your test strips, your glucometer, all those things. So those are big pushes this year to try to figure out our sickest people and looking at your utilization, what's driving our costs, what do we need to put in place to really develop a strategy around what's driving our cost. And those value-based plan designs are much more the norm this year than they have been in the past. And then, of course, leveraging technology, right? So we all love our gadgets. I was joking with one of my clients this morning. In 1989, when I graduated from college, we didn't have cell phones. That everybody carried, this big, huge phone. And that wasn't that long ago. So we, those of us in our 40s and 50s have really seen such a change in the industry and just our lifetime on the technological advances. And it really behooves us in the healthcare industry to use what we can to really just focus on how do we push people to do the right things with technology and information. This is becoming more focused on the chronic illnesses like diabetics, things like that. There's all kinds of new gadgets that are in place for them. So this is something that's definitely coming a long way. And then, of course, I just wanted to add some statistics about transparency tools, advocacy, navigation services, telemedicine, we talked a little bit about that, and then the mobile app engagements to kind of show you that large employers are offering second opinion services as well. Those second opinion services are, again, for your large claimants or the catastrophic illnesses, and really just kind of trying to help them get the best care possible. So in summary, we're finished up. Really what we just really wanted to kind of show you is the surveys are showing, the trends are showing, especially with large employers. And these surveys are a cross section. So they're not just the Fortune 100 companies. This is a cross section of employers across the geographical United States as well as size. So these are definitely trends where we've gone from utilization management and disease management to pushing people to a culture of health. And incorporating population health management with the value-based plan designs into, really just trying to use every resource that we can to get people into the right strategy and the right focus. So that is the summary of the survey. I know after these, we usually take questions. We don't have a lot of time for questions, but you guys have my contact information right there. Again, we'll be posting these slides both on the University Conference Services webpage as well as my webpage, which is mbgrayhealthcare.com. So you should be able to find a copy of these slides up online tomorrow. And if anybody has any questions, I am here. We really feel like a family. We feel like a community. And if anybody just wants to pick my brain, I'm always available. So I thank you for your time today. Kelly, anything to add?
Thank you so much, Mary Beth. Awesome information, as usual. We did record this webinar, and we will put the recording on our YouTube channel later today, and will be linked to our website. And feel free to reach out to Mary Beth, and we hope to see you at a conference in 2018, New Orleans, Chicago, or Las Vegas. Have a great afternoon.
Terrific. Thanks, everybody. Bye-bye. Bye.